Okay, I'm gonna let everybody in now. Actually, before I do that, can you guys confirm you can see my full screen in full view?
Yeah.
Yes. Okay. Thank you.
Thanks for joining, everyone. We're going to wait a few minutes for like any other stragglers. All right, there we go. Welcome, everyone. Thanks for joining us for our virtual open house. If you haven't done so already, please enter your name and organization in the chat just so we know who's with us today. Also, please click the speaker view at the top right of your screen instead of gallery view. And if you have any questions, just throw them in the chat and I'll read them off at the end of the presentation. And for anyone who hasn't had the opportunity to meet me yet, my name is Taz Mays. I'm the Community Outreach Manager for the Willoughby location. And now I think it's a good time to introduce you guys to our speakers today. First, we'll have Dr. Sean Ryan. He's one of our founders and our Chief Medical Officer. And we also have Michaela Taylor, our Vice President of Clinical Operations.
Take myself off mute. Thanks, Taz. Hi, I'm Dr. Sean Ryan. Hopefully everyone can hear me. I believe you can now. We'll start this with just by saying that, we're not going to read through our CV or mini CVs here. Michaela can introduce herself. But I am Dr. Sean Ryan. I'm board certified in both emergency and addiction medicine and founded BrightView several years ago now, which is kind of hard to believe, based on the key concepts of science-based treatment, compassionate care, and ready access. Really, those three things have driven the core of the organization for this many years since we first came up with the need, and it's driven growth and access into new communities every other month, it feels like. And happy to talk to you guys about what we do today and why we're here. Michaela.
Yes, I'm so excited to be with you guys today as well. My name is Michaela Taylor, and I've had the pleasure of being with BrightView since 2015. I'm licensed in the state of Ohio as a counselor, and I just absolutely am really passionate about this population and what we're trying to do with bringing this model to communities, and excited to bring this model to yours and talk to you more about the services that we provide. So I'll turn that back over to you guys.
All right, so our Willoughby location opened on May 15th, and we currently have 61 sites across Ohio, Kentucky, Virginia, Delaware, and North Carolina. I'm pretty excited for our time together today, not only to showcase our facility, but more importantly, for you guys to hear from our speakers, Dr. Ryan and Michaela. BrightView is looking forward to providing patient-focused quality care to our community. And during this open house, Dr. Ryan and Michaela will talk about medical excellence, clinical excellence, and treatment innovation. So on to you, Dr. Ryan.
Thanks again, Tess. So this slide, I think, really represents a fair bit of the reason of why, why we're here, why we're talking to you guys today, why we're continuing to enter in communities across several states in the Midwest. And this is really what I saw, I guess, over a decade ago. It's hard to believe how many years I've been practicing medicine at this time, but over a decade ago, working in the emergency department, as the opioid crisis really ticked up, seeing patients come in sometimes several times a day. Remember the last time I actually worked in an emergency department shift in 2017, which I can't believe that's 5 years ago now. Saw like 6 overdoses, a few of which were fatal in an 8-hour shift in the emergency department. We see this deluge of folks with all types of substance use disorder and mental health issues come in, have clear, potentially and often life-threatening, as is the case with opioid overdose, signs of substance use disorder. We would do a minimal assessment, maybe some stabilization, and that's maybe, and potentially give them a little bit of, it says services and care here. I would say there wasn't much going on at that time. It's better now, but still lots of room for improvement in our acute care settings. But we might give them a little bit of medication and stabilize them, watch them for a minute, and generally just hand them a pamphlet and say, hey, this wasn't exactly how we would state it to them, but the reality was, we were saying was, I realize we have seen you for a life-threatening medical condition, especially overdose from opioids, and here's a pamphlet. That should sound just as crazy as it comes out of my mouth to most folks. And so that to me was at polar opposite and at odds with good medical care and especially good holistic human care for mental health and substance use disorder. And seemed, and has been upheld actually legally by different entities like the Legal Action Center as what they call an EMTALA violation, or a lack of good care in an emergency setting. And that's where we started. I couldn't tolerate that anymore in my own community in the middle of Cincinnati. I was working at 2 hospitals at the time, seeing it at both places and everywhere else as an administrator for Mercy Health, where I oversaw a lot of different functions. And we decided to disrupt this cycle. And now, many years later, we've done that for thousands and thousands of patients, saved a lot of lives, changed the kind of the trajectory or the direction of people's substance use disorder and recovery by putting a block as many places as we can in this cycle, and making sure that when folks are identified with substance use disorder, whether it be primary care, emergency setting, hospital, social services, that there is, as I stated, good science-based care that can be referred to same day, next day, including medication-assisted treatment, which we'll talk a little bit about more later, and that they would be seen compassionately for it. And I think that last part is probably the most important, because I've seen, unfortunately, thousands of cases of non-compassionate care in every one of those things I just described. Next slide, please. A little bit more about just some details. Again, won't read this for you folks. I'm sure everyone can. I was trained as an academic physician, did my MBA during residency, really focused across my career on a lot of statistics, math, and science related to good medical care and other issues and good public health services for folks. And so we constantly review the data of what's going on in order to have what we describe as kind of best directionally accurate strategies on how to address folks. And a lot of this data that you're seeing here and several other places, that's, I'm sure everyone's read multiple publications on the issue, demonstrates a complete lack of good quality care. Also demonstrates the absolutely changed trajectory of recovery or chances of getting better for folks if they do receive good care. The issue on I think kind of the second bullet point down, that folks aren't getting treatment after an opioid overdose should sound ridiculous, because we don't accept that for cardiac care in the United States. And there's a long history that you can read in some of the published literature we've participated in around in the 50s and 60s, if you had a heart attack, you went to the hospital, maybe got an aspirin and some morphine, and good luck, and you died about 1 out of 3 times. That was not okay. And after trillions of dollars of the U.S. medical spend, you can now get excellent, world-class cardiac care in the United States, which is not, what we're seeing for substance use disorder, or particular opioid overdose. The model we have isn't working. I don't really need to elaborate too much on that. Every year, I am disappointed to see a new increase in this drug overdose and suicide death in our country. I participate in a lot of those national statistical evaluations and really dig into why they're that way and what they mean. But by and large, it's not working. And that's what I tell folks when I'm testifying in front of Congress or whatever setting it's in. The proof is in the pudding. So we're all working really hard. I think we've made some good strides. And in Ohio specifically, where we have a strong presence, we are bending that curve, especially in counties where we have a strong presence. But nationally, we still have a long way to go. I'll tell you that the last kind of slide section here is very important to me. When when we started BrightView, we really just started with the core concepts I stated, but then also what I would describe as systematic barrier reduction. And I have been in medicine for a long time. I have never seen folks with a medical condition like opioid use disorder have so many barriers to try to get better. It's the hardest thing to get over and one of the most life-threatening conditions in the country. And we at BrightView really take it very seriously to deconstruct or destroy those barriers, whether they be insurance or transportation or medication or whatever it is, so that we can help folks overcome those external challenges, which can be, sometimes look like the Great Wall of China to folks trying to get into recovery. Next slide, please. We do, this is just a list of the ways that we break those barriers down that I kind of alluded to. That include things like walk-in treatment. I know that when we started the concept of BrightView with Ready Access, of course, I was day one, and Michaela was actually there fairly shortly after day one. I was seeing basically every patient, and she was seeing almost every patient. So that wasn't a sustainable model. But since that time, we have actually been able to maintain a lack of wait lists, see people on demand as much as possible. And that concept, like I said, when we started BrightView across the field in the country, was very foreign concept. Folks, 2-week wait list, 2-month wait list, or longer. And that just is not, wasn't acceptable then, it's not acceptable now. And we spend a lot of our time on the last couple of points, especially the last one the second last one where we participate in anti-stigma campaigns and systematically rooted out both internally with our staff and with patients and their own sense of recovery, so that folks can really feel like people and that we're treating a neurochemical and a neurobiological disease as we should. Next slide. Michaela, you're welcome to tackle this, or I will. This is as you.
Yeah, I'm happy to touch on this. So yeah, I think the thing that I like to highlight on this slide is that some people will be like, so you only offer outpatient, why aren't you offering like inpatient or residential services? And what I think is really significant here is recognizing that research indicates that less than 20% of those with a substance use disorder actually require inpatient care. And so we really have wanted to focus on being an outpatient program and really taking that rational approach to addiction treatment. Of course, we want to make sure that we're assessing people for the appropriate level of care, referring them to a higher level of care, when they're needing that in cases such as like acute alcohol withdrawal, et cetera. However, we recognize that, after this acute stabilization, people are really going to need ongoing care due to SUD being a chronic, relapsing medical condition. This type of disease requires a comprehensive treatment response. And just like any other chronic condition, you don't manage that condition long-term from a hospital bed. You want to make sure that you're referring to a specialist outpatient office where that can be managed ongoing and long-term in a sustainable way that fits into people's lives and something that they can continue to engage in long-term. And so we recognize that if we wanted to help and support and reach more patients in this space, we definitely wanted to focus on providing outpatient care because this solves the longer-term problem where this outpatient treatment needs to be delivered. This has other stats on here, but I won't read all of them off to you on here. But I think it really just highlights that, we embrace that long-term continuum of care when it comes to wanting to partner with agencies that are specializing in those areas and really focusing on our specialty, which is outpatient and then intensive outpatient. So outpatient is your traditional outpatient, and then intensive outpatient is exactly like it says intensive outpatient, which requires quite a bit more group therapy. But we really want to individualize that and making sure that we're helping people fit treatment into their lives in a sustainable way so that we can be confident that we're going to help set people up for success long-term. And that we can help them then also have long-term recovery, even when they're no longer needing active treatment, but long-term continuing care. And so patients really being able to identify how long, engaging in those ongoing checkups are really going to serve them well. I've had the pleasure of working with people that I've still continued to see since 2015. They're obviously in a very stable place and no longer needing active treatment in sustained remission, but they've engaged with BrightView long-term because they recognize that, and in order for them to want to feel confident that they're, taking care of themselves and having those checkups and being stable, that they want to have those ongoing services, and that's helped them maintain their recovery long term. Can you go to the next slide, please? I'll turn this back over to you, Dr. Ryan.
Thanks, Michaela. So in 2016, as this journey continued, I was fortunate to participate in the Surgeon General's report on drug and alcohol use. That was a physician named Dr. Vivek Murthy, who is now the Surgeon General again. And really, it was a very comprehensive and well-written report of the state of affairs of the past several decades of substance use and alcohol, or all substance use issues, and endeavored to talk about things, including prevention, including psychological treatment, including medications, and showed that if you do a good job of the holistic biopsychosocial treatment model, that it does the things that we want it to do: reduce substance use, reduce risk of overdose and associated criminal behavior, and reduction of transmission of infectious disease. Not surprises, and obviously very important targets for all folks involved in the field. But just kind of reiterated the mounting and growing evidence in the public health and medical field and psychological evidence field that the right way to do this is what we're doing. And that to me, was, I guess it was good to see a Surgeon General's report, something of that magnitude, and to talk about it. It's still valid. Not much has changed since the publication of 5 years ago. But still, in doing data, and I had a conversation with some federal legislators the other day, it still seems like a lot of that biopsychosocial model is not being proliferated around the country. And then we are surprised when every couple of months the CDC comes out and says, hey, this is still getting worse. That doesn't make a ton of sense, as it shouldn't. And what that really, by and large, focuses on is the fact that the medical best practices aren't being followed. So in many states, less than 50% of citizens have access to any sort of medication for substance use disorder at all, much less at volume, much less the right ones, much less all the other stuff and the right doses and such. At BrightView, we probably have thousands of years of collective medical experience in substance use disorder amongst all of our addiction specialists and other medical providers. And that allows us and provides us with the support to make sure that we're constantly reviewing the evidence, that we are on an individual and an organizational basis recommending the right medications, whether they be Vivitrol or Suboxone, Methadone, et cetera, for opioid use disorder, or naltrexone, et cetera, for alcohol use disorder, which is a very important topic that shouldn't be underplayed. And because of that medical experience and focus on the science, we really do, just like I would with anticoagulants or diabetes medications or whatever, recommend the right best dose of the right medication for the patient. That's our Hippocratic oath. That's our medical legal liability avoidance. That's our duty as physicians, nurse practitioners, et cetera, to make sure that's correct. What we all too often find out in the public sometimes is either the complete barrier to medications for all substance use disorders for what I would describe as fairly uninformed reasons, or even intervention on dosing and things like this. And I would just, advise folks that are involved with our patients or in the field at all to remember that, I'm not a therapist. I have a lot of psychological training, but I'm not Michaela. And so we work together to form plans for patients for their best plans of recovery. But I venture to say there's been very few times that Michaela has ever called me and recommended dosing or tapering or changing medication or whatnot. And we form those patient plans as a holistic, very informed strategy. And that's important to us. Like I said, we have a robust communication system across all of our organization, across multiple states, where our medical providers can get a consultation from a board certified OBGYN addiction double boarded physician, which is unique if they need to for a pregnant patient. And because we take that so seriously, we hope that folks that are sending patients to us understand that to be honest with you, to summarize it simply, that we know what we're doing in regards to medical treatment. And we do try our best to make sure that we're, putting that patient and provider relationship first. I'll turn it over to Michaela to talk about kind of their side of the equation.
Thanks, Dr. Ryan. Yeah, so when we think about clinical best practices, we really want to make sure, and I'll just echo Dr. Ryan in saying having a holistic approach, we really bring expertise in like biological, psychological, social setting, and really wanting to provide that wraparound care for our patients, and really wanting to use evidence-based treatment and follow what the science is saying regarding what's really going to set our patients up for success and make sure that they can have, develop successful long-term recovery. We recognize that people who are engaged in that comprehensive treatment are going to do better. End of story. Like that is what sets people up for success. And so we prioritize that in every single one of our centers. And so, every one of our centers has, a clinical supervisor that's overseeing the clinical care and has counselors and case managers. And we have nurses and medical staff and MAs, and everyone's working together really as a joint treatment team and really wanting to individualize every single person's treatment, making sure that we are truly wanting to make sure that we can speak to any barriers that they have, help them overcome them, and help them work through the things that they're setting out in their treatment plan. So on the clinical side, we do, an assessment, we do individual counseling, we do group counseling, we do case management, we do peer support, and we love being able to have a wide variety of interventions that we can put in on the clinical side that will really help patients really with the specific areas that they're struggling with. Case management really does help a lot with those barriers when it comes to care coordination, such as crisis management, linking to, legal services, vocational services, transportation, housing. Because again, our goal in this is not just the absence of using a substance, it's the fullness of life again. It's being able to be engaged in your life and achieving your goals and being able to move forward in whatever that looks like for you. And we also really value community collaboration, being able to get connected with other agencies and other departments in the community, and really being able to serve our patients well through that collaboration, through that coordination, and being teammates in that way. One of the other things that we prioritize as part of our clinical best practices is the harm reduction model. So we recognize that SUD is a chronic, relapsing, and oftentimes lethal medical condition. And our intervention and delivery have to reflect that understanding and complexity with pursuing this biological, psychological, and social etiology. So we recognize that with that harm reduction model, we really want to operate from a non-punitive clinical philosophy. We wouldn't do that in any other area of healthcare. If someone with diabetes came in and they were struggling with, weight loss, or they're struggling with exercise, they're struggling with eating right, we would never shame them into doing better, right? We would want to make sure that we meet them where they are, that we identify the things that are holding them back from being able to move forward in their recovery, and for being able to do that in the same space that we do any other healthcare. We don't want to punish people for from seeking treatment for the condition they're struggling with. Sorry, you're too sick for us to help. We want to make sure that we're able to meet them where they are and walk alongside them in that journey, just like we do in every other area of healthcare. Can you go on to the next slide, Katie? Thank you. And so how do we know that what we're doing is working? And this is a slide I just get so excited to see. We have actually done a lot of research at BrightView and really wanting to pursue our goal of making sure that we're operating with excellence. And we actually did a study of over 12,000 patients over a period of 3 years. And we were able to identify what we can do to specifically set people up for success in the interventions that we're providing, and how we're wanting to make sure that we're having that holistic model that works for people. And so, I think the stats speak for themselves. Does addiction treatment work? It does work. And we're proud of that fact. Some of the things that I always love to highlight when I look at this is thinking about that BrightView patients are decreasing their use of illicit substances by nearly 70% on average within the first 90 days, with many of them achieving complete abstinence. And to me, I just think that's an incredible statistic when you think of how many people are coming in and maybe they've been using for decades, and to be able to within 90 days decrease their use by 70%, or some achieving full abstinence at that point, I just think is phenomenal, just in the way that we recognize that the interventions we're providing are providing actual transformation. And so that's why we value what we're doing from that comprehensive cycle. And you can see kind of the stats of what that speaks to. Another one that I always like to highlight, and this is just a special one for me, and this looks like the smallest one on the screen, but it talks about in the first 90 days of treatment, the BrightView patients spend an additional 3 days per month on average with friends and family who support the recovery. And to me, I think this one just hits home, and thinking about how many people have loved ones and how many patients have been separated from their families due to a wide variety of things. And so to be able to be back in their families' lives, an average of 3 days a month, I think is huge. Just thinking about the transformation that it means for their parents, for their kids, for their siblings, for their spouse, whatever that looks like, that is a huge transformation that when people engage in treatment and engage in that lifelong recovery, it's not only impacting them, it's impacting their families and it's impacting their communities. And it's having that ripple effect across the board for them making those choices and choosing to engage in treatment. And we're just so proud to be a part of that and proud to bring that to the community. Dr. Ryan, I'll turn it back over to you.
So, are you gonna do the feedback or?
Oh, go ahead, Tess.
All right. At BrightView, we value feedback from our partners, like those of you on this call today. Your feedback helps us assess how well our team is doing and is a critical resource for improving our relationships and our services. Please feel free to share any questions or comments that the doctors can address at the end of the slideshow. Now let's take you guys on a brief tour of our site. Right here, you're seeing our facility as our patients do. We're proud to provide a clean, welcoming environment where they can be treated with dignity and respect. Here you're seeing the exterior of our building, then our waiting room and lobby where our patient services representative gets patients checked in and ready to see our providers. Here's our nurses station and medical work area. Here's where our medical team begins the intake process and begins medical care. In the engagement room, our patients can relax and watch TV in between seeing providers. Light snacks and refreshments are provided in the engagement room. Also shown is our case management and counseling offices where our patients meet individually with staff. Pictured here is our group therapy room, where our counselors provide several groups per week. The OTP dispensing area is a service that will be available in the coming months. This area is where medications for addiction treatment can be provided on site. We also have lockers where patients can secure their belongings while they're here. And that concludes our tour and pictures. In addition to providing a bright and clean treatment space, we also realize how important easy, no hassle scheduling is. So just to reiterate, we have a 24/7 access line, as well as online scheduling. Walk-ins are available Monday through Friday until 3 p.m., offering treatment on demand with no wait lists. Our goal is to make it as easy as possible to schedule patients. We believe that if someone wants help for addiction, they can get it today at BrightView. And now at this time, we'll take any questions from the chat and any questions received during our registration process. All right. I guess, Dr. Ryan, are you answering these?
Yes, sir. As long as they're in my wheelhouse. Let me see. Are we talking about ones that might be in the chat or ones that have previously been pushed forward?
There might be some in the chat, but I'm just going to read off the ones I got in the first place. All right. How does BrightView decide on a new location, and how did that process lead BrightView to Willoughby?
Sure. So it should make some sense that the nerd side of myself and many of the other executives really follow a pretty diligent mathematical process. That sounds overly kind of analytical and removed, but it's not. So there's only so many folks and physicians and providers and patients in need and resources, et cetera. So we have to allocate those resources appropriately to the communities in need first. We also do have virtual services for those places where we don't have brick and mortar facilities, as I think most people know, in order to extend our reach and reach those folks in more rural or distant areas. But really what we do is look at the math of the problem in each community, but the population and the overdose rate and like 50 other things, and then meet regularly and talk about the next best place to go. One of the reasons we like to do that is, in contrast to what we've seen in the field in the state of Ohio specifically, folks kind of opening up shop and then shutting doors and really causing more community turmoil than anything. We've never really done that. Actually, I don't think we've ever done that. And so we want to take a little bit more time to review the need of the community. And then what we do is review at the ground level with community members. So we have folks that travel or already live in the communities that we're evaluating. And we will move forward based on kind of that two-part process, so that we are sure that the need is there and it's urgent. And we're sure that we have the people that we can go to give the treatment there. And then meeting with community members to make sure we're not missing something, whether that be criminal justice or healthcare or whatever else. So it's a very multidisciplinary and involved and thoughtful process. And that's why we've been successful in landing where we've landing and staying there.
Works for me. What are the qualifications of your medical providers and counselors?
I'll talk about our medical providers, and Kayla can jump in on their side of the house. So we try to recruit as many board certified, and what that means, folks, that don't know, is folks that have, in addition to their medical medical school training, they have residency training, and then on top of that, have further training to be board certified and take a test to be so. So we recruit as many of those, it's the highest level of training, board certified addiction specialists and psychiatrists as we can. Not surprisingly, I think most folks would be, say, oh, well, it'd be great to have everybody with that level of training, but that's not reality. It's not reality in any part of medicine, to be honest with you. There's still non-board certified emergency physicians out there practicing in emergency departments. So we seek those folks like myself who took the time to do that and went on about our process of developing internally from folks. So what we also like to do, because there's not enough of those folks, and I do a lot of state and federal workforce initiatives across all types of staff, is we will take the time to develop training programs, very, pretty in-depth, several month training programs to put folks through, depending on their level of expertise. So if they don't have board certification, there's still a medical doctor or osteopathic doctor or nurse practitioner or whatever is necessary. They still have the appropriate certification, but then we put them through both education on addiction, which is initial and ongoing, meaning, like I said, somebody could right now message me on Teams and ask me a question about a certain dosage of medication if they felt the need. And so we, I hope that kind of long-winded way of saying a lot. The qualifications are a lot, and we're very serious about maintaining that level of quality. Michaela, I think their department has similar strategies.
Yeah, for sure. So 90% of the counselors that we have at BrightView are actually master's level trained. And so we really prioritize wanting to make sure that we have people who are, at the top of their field too, and want to make sure that they're providing the best quality care and oversight. But we also value wanting to help bring more people into this field and into the work of addiction as a whole, and being able to embrace this kind of care model. So we also hire people who are dependently licensed, meaning that they have a license to practice and they've received training and education for that, but that they are not independently licensed, meaning that they still need oversight of someone who has their independent license. And but we are really proud of the fact that we do try to provide excellence with the people we're hiring and in the type of care and oversight we're seeing, and that we also really prioritize supervision and development of our staff. And so we require weekly group supervision, individual supervision, and development of all our clinicians, regardless of licensure, just because we want to feel confident that we're prioritizing our own development as a team and making sure that we're showing up for patients in the best possible way. Hopefully that answers your question.
All right. Thank you for that answer. Take a question from the chat here. Sorry. From Bill. Sorry, I can't pronounce your last name, but how far out do you follow up with patients?
I'll take that one to start. I mean, I'm not sure if the question is how long do we see a patient or how quickly can we see them? And how quickly is almost immediately. It's kind of like more on the patient's schedule and their life than ours. In regards to how long we'll see the patient is as long as they need us. So, if they're not that sick and we can resolve to a pretty infrequent visit schedule in months, then we'll do that. If they're very sick and it takes longer, then we'll do that. If they need long-term maintenance, medication and therapy, then we'll do that. So it's basically any measure of time necessary as dictated by their recovery plan and relapse, which happens. the general sentiment is each person's an individual. And so, I've had patients throughout, as Michaela stated, several years and maintained their stability through that. And if that's what they need to stay in their recovery, then we're going to do that.
I'm going to read a question that I commonly get. And what's the ratio of BrightView patients using Vivitrol versus Suboxone?
Actually, I don't know that I don't have the number off the top of my head. We do run reports on things like that because we want to make sure that we're tracking, but it does get a little skewed because we also see every other substance use disorder. So because it's not just opioid use disorder, or patients have multiple substance use disorders like alcohol on top of opioid or whatever, it's a little more of a multifactorial assessment than, who has what exactly. We do have more patients on, to be honest, of buprenorphine or Suboxone is the brand name than naltrexone or Vivitrol, the brand name, because it's more effective. And that's based on studies we've read and dealt with as an organization for decades. The studies are decades old. And so we follow the science, and to do anything otherwise would be malpractice.
Okay, cool. That's great. Sorry I can't get to everyone's questions, but I think we need to wrap it up here. But I just want to say it's been a pleasure to meet all of you, and I would love if you guys schedule a tour so that we can show you off our beautiful new facility. Additionally, next Tuesday we're having a ribbon cutting ceremony, the 28th at noon. So come through. Lunch is provided. I'll be doing tours. Also, we look forward to forming strong and lasting partnerships with all of you today in our community. We're happy to answer any other questions you may have or listen to any feedback you can provide. Thanks for your time, guys.